one of the best introductions I've had. It's an honor to be your student and an alumnus of Shankar Netralaya, and I'll be quickly sort of tying in probably everything that we've been discussing, because most of our treatments and most of our management of all of these diseases is linked to this single investigation, which is the OCT. So I always tell my students and fellows that you have to learn a little Greek and Latin to be a good doctor, or to at least understand the terminology. And the OCT is nothing but the optical coherence tomography, where optical means it's something related to light. Coherence refers to the fact that all the light waves are in phase. And tomography is a portmanteau of Greek words. Tomos means to cut or make a section, and graphy is a pictorial depiction. So we're actually using light and the coherent properties of light to make a pictorial depiction of a section of tissue. So the optical principle is basically light is shown into the eye, and when it reaches the retinal layers, at every interface, there is some amount of light which is transmitted through and some amount which is reflected back. And subsequently at the next interface, some is transmitted through and some is reflected back. And this continues to happen. And ultimately the phase difference between the emergent rays or reflected rays of light and that light which was incident into the tissue is compared. And this comparison allows us to get a pictorial depiction of the optical properties of the tissue. Now this basically it determines relationship between light reflecting interfaces, and those interfaces are what is most important. And the principle, as everyone knows, is the Michelson interferometry. Now a little digression. Albert Michelson was an American by nationalization. He was born in Prussia, but as a 2-year-old child with his parents, he moved to the United States. And it's a very inspiring story because he petitioned the President of the United States, Ulysses S. Grant, who then got him a position at the US Naval Academy of Science, where he went on to become a prominent researcher. And he is the first American to receive a Nobel Prize in any of the sciences. And it's his principle today that we're using in the optical coherence tomography. So we're all familiar with the picture of a retinal OCT. We'll be going through a few of the scans. This is predominantly for general ophthalmologists so that we can all understand how to interpret an OCT. And with today's machines, which have higher and higher axial resolution, you can really get all those 10 layers and probably more of the retina that we used to study in our post-graduation days, and which we found so hard to memorize and remember. But now you can really see those images, see those different layers on the OCT, and they're called by different names, but you can also image beyond the retina into the choroid and sometimes beyond the choroid as well. So we'll be restricting ourselves basically to different line scans of the retina and describing them in under these various headings, because it's always useful to follow this schema where you go from top to bottom, so you don't miss out anything, and you can also get the relationship of different layers with each other, and that helps you diagnose what the pathology is and where the pathology is. So the first interface is the Vitreo-Retinal Interface, and these are just some line scans which show you a layer lying on top of the retina, which is an epiretinal membrane. And you can see in the top line scan that it's sort of just draped over the retina, but it's also pulling the retina into folds, especially the internal limiting membrane is getting a little folded at the top over there. And the lower scan shows how the retina is sort of becoming thick. And of course, this scan is not through the fovea. This is an extrafoveal part of the retina. But you can see that the retina is also being pulled up and becoming thick because of this epiretinal membrane. Some more scans through the fovea of different patients, which show how the retina is being pulled centrally and producing this distortion of the foveal contour. And this is what would clinically appear as a hole, but is not a true hole. It's a pseudo hole. These are examples of epiretinal membranes with pseudo holes, which look very bright red on clinical examination, but the patient generally has excellent vision, 6/9, 6/6, and is mostly asymptomatic. And an OCT will prove to you that there is actually retinal tissue at the base of the hole, and these patients don't require any treatment in most cases. Coming to something a little different, this is an antero-posterior traction or a vitreofoveal traction. You can see that the posterior hyaloid face is attached to the disc at the left of your screen, and is detached over the rest of the macula, but gets attached at the fovea and pulling the fovea anteriorly, producing distortion of the foveal contour. And if this progresses, many patients go into, not many, not all, most of the patients don't end up in macular holes, but a significant minority do end up with full thickness macular holes, some examples of which are seen in this slide. Now, moving on into the retinal architecture, here you can see cystoid spaces, and they're large fluid-filled cavities or spaces within the retinal layers, and they've caused the normally concave retinal surface to now become convex, like a little mountain or a hillock. And you can see that there are these small collections of fluid within the retinal architecture. And here, which has already been described in the discussion on macular edema and vein occlusion, here you can see a neurosensory detachment or accumulation of fluid in the subretinal space in association with accumulation of fluid within the retinal substance. As opposed to this image, where you can see the fluid is only in the subretinal space, that is between the neurosensory retina and the RPE, but the retinal architecture is well maintained and there are no fluid-filled cavities within the retina. And this picture is of central serous chorioretinopathy, which often has an underlying RPE abnormality or irregularity, which is evidenced over here just underneath the fovea. Another image which shows a sub-RPE space, commonly known as a pigment epithelial detachment or a PED. This PED is completely black within, so it is a serous PED as opposed to other types of PEDs. But this is a serous PED, which is located just a little temporal to the fovea. And patients may have some metamorphopsia because of this PED, but in many cases, they're totally asymptomatic. And this is a patient with subretinal fluid as well as sub-RPE fluid. And you can see a large bubble-shaped or dome-shaped PED with fluid under the subretinal space. This is another example of a central serous chorioretinopathy. This was discussed very nicely in the previous talk by Dr. Vasumati, the OCT pictures in diabetic macular edema. And as she very nicely mentioned, this is how one would actually stratify treatment options for the patient. And certain treatments would be preferred depending on the OCT pattern. I won't go into that again for risk of repetition. But this was probably not covered in previous talks. So OCT in neovascular AMD, here you can see that in the subretinal space, there appears to be some mushrooming of a structure which is spreading in the subretinal space, and you also have subretinal fluid. This is the CNVM, or the neovascular membrane that is sort of breached through the Bruch's membrane and RPE and is now growing in the subretinal space. Other features in neovascular AMD include the presence of pigment epithelial detachment, intraretinal fluid, which is evidenced within the retinal architecture, and subretinal fluid. And combinations of these can be seen in different patients and at different time points of treatment. These are large PEDs, which are unlike the serous PEDs seen in central serous chorioretinopathy. There is material within this PED. This is a fibrovascular PED. And hyperreflective foci can sometimes be seen, which are accumulation either of inflammatory cells and microglia or exudates from the neovascular membrane, or in some rare cases, pigment derived from the RPE. And subretinal hyperreflective material, which is also thought to be either hemorrhage or resolving hemorrhage or fibrinous material that is exuded from the membrane. And the end result, which is this formation of this subretinal scar, which is an endpoint of treatment. Many of these cases or instances we've discussed are just of the line scan, and most of the time the patient carries these large maps, multicolored maps, which are difficult to understand. But it's the most important feature of all of these, I would still emphasize, are the line scans. The morphology of the retina is probably the most important. The maps provide quantitative information, and here on the bottom right, you can see the 9-sector map, which has the central subfield and inner subfields, 4 inner subfields and 4 outer subfields. And each of those numbers within those subfields are nothing but the average thickness of the retina at that particular location. While I would not advise looking at absolute values, these colors and these values can give some indication over a period of time whether a patient is responding to treatment or not. But I would still emphasize that the most important feature to look at is the morphology of the retina on the line scans. This is another type of printout that one may encounter, which is a cross line. The top scan shows the horizontal line scan through the fovea, and you can see the optic disc also to the right of your scan, and the lower one is a vertical scan. So it's also useful to know whether you're looking at the retina in a horizontal section or a vertical section. There are a few limitations which I'll just quickly cover. Some which are procedure related, mainly that the OCT has to be performed in a sitting position, which is maybe impractical for very small babies or for very elderly patients who are not able to sit up. It requires clear ocular media, and there are certain principle related limitations which we'll see some examples of. So as you can see, the OCT, as we discussed also earlier, is a light-based technology. So if there is any structure which is opaque to that particular wavelength of light, it casts shadows, and you can see these long linear shadows cast by hard exudates within the retinal substance, and you really cannot see the continuity of the layers behind those structures. So one should not think that these are discontinuities in the layers behind, but they are simply shadows that are being cast by structures in front. Or for example, in this case, where you can see these large shadows being cast by dispersed vitreous hemorrhage, which is lying on either side of the fovea, and you can therefore not see the continuity of the retinal layers on either side of the fovea. At the same time, you can have window defects. Here the RPE is atrophic, a large patch of geographic atrophy. And if you look at the corresponding OCT, you can see that there is this window where you can very nicely visualize the choroid and the choroidoscleral junction, because there is no RPE to attenuate the signal of light passing through in that region. Some important interpretations. Here you can see the raster scan, and there are just two neighboring scans that are being focused on, or we're looking at this point in time. If you look at only the line scan which is given above, you may be tempted to think that the vitreous is completely detached from the retina, and only when you look at the lower scan do you realize that it's actually very much attached and thickly attached at the fovea. So this would be very relevant when one is planning surgical treatment of these patients, because this would definitely require surgery, as opposed to the top scan. If it was a detached vitreous from the retinal surface, one may have been tempted to treat these patients with pharmacotherapy, intravitreal injections. There are certain artifacts, as was shown in earlier slides, when we're looking at the quantification of the retinal thickness and layers. There may be misidentification of inner and outer layers, but as technology advances and as there are superior software algorithms, these become less and less common. Here you can see in a full thickness macular hole, the software has not recognized the discontinuity in the center and has considered the retina to be intact, and you would not therefore get the apparent thinning which should have been depicted in a map through this scan. Patients with very high myopia and posterior staphylomas are prone to this particular artifact, which is a mirror artifact. Here you can see the retina on the right side and a mirror image of the retina on the left, which is a troublesome artifact in patients with very high myopia. And in this case, the retina has actually gone beyond the scan limits, and you really do not get much useful information because this is an out of register artifact. When the patient blinks during the scan acquisition, you get dropouts of the scan. And here you can see this black band, which is because the patient blinked while the scan was being taken. With faster and faster image acquisition, these artifacts are going to become less and less. And in most cases, the machine does prompt you that the patient has blinked during the acquisition, and you are invited to repeat the scan rather than save this particular scan for analysis. So just to conclude, OCT has really changed the way we look at the retina over the last probably 20 years, but there are inherent limitations in the technology, and therefore knowledge of these limitations is essential for proper interpretation. Thank you so much for your patient hearing.